Hello, I'm Dennis DiNicola, and I want to thank both ICC and IDEX for giving me this opportunity to speak specifically to feline hematology. Before we get started, I want to bring to your attention the resource tab that's identified on your screen. This will bring you to the IDEX hematology website where you can get more information about the hematology solution that's available to you, but it also gives you an opportunity to fill out a contact form if you want to receive more information about that. There's a lot we want to cover in this presentation. I'm going to go through a very brief overview of production of red cells and platelets. Then we're going to really spend a lot of time on the CBC results themselves. I don't think most people really grasp the value of all the different parameters we provide you in the CBC. So we'll talk about that and give you kind of a logical way to approach the data. We're going to talk about platelets and platelet clumping and how that interferes with our real appreciation of the numbers of platelets that play a pretty critical role. So we'll spend a little time there. Then I'm going to make a quick list of some of the more common feline red cell and platelet abnormalities we see day in, day out in the practice. We're going to try to put all this information together with a few cases at the end. As the title indicated, we're going to be focusing on red cells and platelets in this particular webinar. White blood cells will be covered in an additional webinar a little later. So let's start our journey and talk about the beginning of time, the red cell production, erythropoiesis, and the platelet production, thrombopoiesis. It's important to remember that all of the different cell types we see in the blood originate from a single pluripotent stem cell. However, it's also important to note that the bone marrow doesn't respond as a single unit. Production of individual cell types are individualized based on various stimuli from the peripheral blood, cytokines, oxygen tension in the case of the red blood cells. So we don't see increased production of everything when one cell type might be needed. When we zoom into the red cell production itself, you'll see there's an orderly process of development to the mature red blood cell. Cells get smaller in size, eventually they lose their nucleus, and then they get into circulation where they'll be in circulation for 80 to 120 days, depending on the species. In this slide, you see photomicrographs of the individual cell types matched to the cartoon characters in this production process for the red cells. An important point, though, you need to recognize that the whole time only takes about 5 to 7 days. And in reality, we can shorten that down to 3 to 5 days if there's a tremendous demand in circulation for more red blood cells. Changes we see are decreasing size of the red cells precursors. That's because of the division process that takes place. We see the nucleus become more and more condensed, and eventually that metaerythrocyte loses that nucleus spontaneously in the hematopoietic tissue. Cytoplasm becomes less and less blue as the cells lose their RNA content, and the cytoplasm becomes more red-orange, matching up eventually to that mature red blood cell as hemoglobin is accumulated in those cells. I like using this diagram because it demonstrates the effectiveness of the red cell production. One cell committed to the red cell series theoretically yields 16 mature red blood cells. And if there's a demand, all we have to do is push more cells to the red cell series into that ruboblast category, and then we can get exponential growth of the cells for the peripheral blood. If we zoom into the platelet production line, you'll see something dramatically different than most of the other cell lines. In the progression of maturation within this cell line, the cell gets bigger and bigger to the end point of the megakaryocyte, which is a very large cell that you'll see in the next image. And the platelets, the end product, are actually fragments off of the cytoplasm. These photomicrographs really don't give a good justice in the size of the megakaryocyte, but it does demonstrate the increasing size during the maturation process. It also shows you an elongated projection off of a mature megakaryocyte where the platelets will fragment off. And eventually those little clumps of platelets will individualize before they go into the peripheral blood. And it should be noted that If there's a tremendous need for platelets, we can start shedding these platelets off in earlier stages. It doesn't have to go all the way to the end of the maturation process. Now let's get to the meat of the presentation, and that's talking about the CBC itself. And we're going to dissect that and look at each of the parameters and help you understand why you need to look at them and how do you interpret them. When we mention complete blood count, I think this is what most of us think about. We have results for the different parameters, we have a reference interval, and we may have speed bars that give us a visual assessment of whether it's increased or decreased. However, we must not blindly accept these results. Many analyzers, even the ones at the reference labs, can be challenged significantly if there are abnormalities, abnormal cells or abnormal morphology in the blood. So we need a way to verify the results. I think most of you were taught that the blood film microscopic review is the way to verify the results. However, that's a big problem because we know that much less than 10% and actually closer to 5% of the in-clinic CBCs actually get a blood film review. Over the years, there's been an evolution in hematology analyzers, giving us more and better data. Throughout that evolution, there's something that we completely have ignored, and those are the graphics that come with each result that you do. And those graphics actually tell you how the analyzer performed on that particular patient sample. And once you learn how to use these, you can use this without having to go to a blood film to verify the numbers. Now, each manufacturer should be able to provide you with some guidance. At IDEX, if you go back to that resource tab on the right, you can get information about the IDEX innovations. There are more than just the numbers in a complete blood count. Cell morphology is critical as well. It provides potentially a diagnosis for us in some cases, but at least gives us direction diagnostically on how to work that patient up. The blood film is our go-to. Clearly, we can identify morphologic abnormalities with that, but we know most people don't look at the blood film. The graphics we just mentioned can actually give us a clue as to when we must look at a blood film. Regarding morphology, these graphics give us more and more information as we progress along this evolutionary timeline. To the endpoint with the ProCyte DX, there really is not a single red cell, platelet, or white cell morphologic abnormality that I cannot predict just by looking at the cytograms themselves. Now, if you want more information specifically about the IDEX products, go to that resource tab. Otherwise, contact your manufacturer of your analyzer to help you identify how to use those graphics. We need a paradigm shift in how we approach the CBC. We must learn how to use the graphics to first confirm the numbers that are reported, and also use the graphics to help us potentially identify morphologic abnormalities where a blood film review must be made. Then we can look at the data. So first graphics, then potentially a blood film, and then the data themselves. Now that we have confidence in the numbers, we can start dissecting the CBC, and we're going to start with the arithmogram. My guess is that you probably don't use all of these parameters. Hopefully in the next few minutes, you'll build confidence and understand how to use all of the values. To complicate matters, we keep adding more and more parameters. The reticulocyte count is something that's unique to the LaserCyte DX and ProCyte DX, where we provide that count in every dog and cat CBC. And we'll talk about that a little later. The reticulocyte hemoglobin, I'm only going to touch the surface of that. That's unique to the ProCyte DX analyzer. Within the arithmogram, you'll notice that there is a set order of parameters, and this is pretty much followed by most analyzers now. What I'm going to ask you to do is try to group some of these tests to maximize the interpretive capabilities. The first grouping I want you to consider is that of red cell count, hematocrit, and hemoglobin values. All of these give us information about the red cell mass. My guess is that you probably don't use all three, but I'm going to try to change your mind a little bit about that. I think most use hematocrit, and I like that because I have a manual method, the packed cell volume, that I can use to validate the results on the analyzer if I question those results. The reason I want to look at these three parameters together is because under both normal and pathologic situations, they follow one another very closely. And if they do not follow one another, like going up in dehydration together or going down together with anemia, there's one of a couple of things that may be present. One, there may be underlying red blood cell pathology, and that's the most common scenario. But two, if you see it frequently on many of your CBCs, that's a potential indication that the analyzer itself may need a calibration attention. The speed bars provided by many of your results show you a rapid way of documenting how well these parameters are aligned to one another. These are CBCs from 3 different cats, and you'll notice that the 3 parameters don't perfectly line up. That's going to be a rare situation. However, you do see that they're relatively close to one another. In these cases, I trust that the analyzer is performing well, and I also don't recognize any significant red cell pathology. Here are the red cell mass parameters from a different cat, and you immediately recognize that the red cell count is disproportionately high compared to the other 2. Since this is not a problem on my analyzer, I must interpret this as possible red cell pathology, and I need to do further investigation. When we look at the rest of the erythrogram, we note that there's a decreased MCV. That means the average size of the red cells is smaller than normal. And in that situation, we have to have a disproportionately higher number of red cells to keep hematocrit and hemoglobin aligned. This is a common situation we see with developing iron deficiency. In fact, we can see this pattern even when all of the parameters are well within reference interval limits. There's another clue to red cell morphologic abnormalities, and that's the RDW that's increased, but we'll talk about that a little later. Now we can move on to the red blood cell indices. And my guess is you probably don't use all of them. You may use MCV and MCHC. Many people are confused about what the RDW or red cell distribution width is, and we'll talk about that specifically. The key point about the indices is that these are all describing the population of red cells in a whole. It's the mean cell volume, the mean cell hemoglobin concentration. So that means we have to have really significant numbers of abnormal cells in circulation before we see values deviate outside of the reference interval. With these indices, we get information about cell size, the MCV, and the amount of hemoglobin in the cells, the MCH and the MCHC. Remember that these represent that population statistic, so they're not really sensitive enough just by looking at them in relationship to the reference interval limits. And we'll talk a little bit about how we can improve the sensitivity in evaluating these parameters. The RDW, as I mentioned, we'll talk about that in just a second. If you're not familiar with the index of individuality, let me try to explain it in a very simple manner. First off, I need to note that the literature that we have, which is abundant both in human and veterinary medicine, speaks to the index of individuality for the erythrogram values. What does this mean? This means that these parameters do not change much during periods of health. So when we interpret the results, we really need to look at previous results from that same patient rather than trying to use the reference intervals provided from a large population of animals. I'll show you how to use this in a few slides ahead. To demonstrate how to use the index of individuality, I'm going to use my own cat, Willow. Willow's a real healthy cat. She's had no problems. She goes to the veterinarian every 6 to 12 months for a preventive care visit where they do a minimum database each time. And we're going to look at Willow's data to see how to interpret it. Let's look at Willow's hematocrit and MCV values over the last 5 years. I pulled the data directly from VetConnect Plus, and in fact used their graphing tool to trend the data. You'll notice that Yes, there is some movement, some fluctuation for each of these parameters, but they're not bouncing all around within that reference interval limits. That's the key to index of individuality, the consistency of the results. So a very subtle change might help me detect early disease development. I've drawn some relatively arbitrary limits for both hematocrit and MCV for Willow. Think of these limits as being kind of a driving lane. And I want to make sure that in future year results, we see them stay within these lanes. If there's a subtle deviation outside of them, I know there's underlying disease. And actually, that can be far superior to looking at deviation from the reference interval limits in these parameters that have that high index of individuality. Let me use a quick clinical case to document the value of the index of individuality. Tina's a cat that came through our community practice, and we actually have about 6 years worth of data for Tina. I was presented to the case on pathology service in 1998, at which time it presented with mild weight loss, intermittent diarrhea, and occasional vomiting. At that 1998 presentation, the workup included a minimum database, and there were no significant abnormalities in hematology, chemistry, or urinalysis. They did diagnostic imaging and identified thickened intestinal mucosa, which led them to a biopsy to get to the final diagnosis of inflammatory bowel disease. Remember, in 1998, the MCV and hematocrit are within reference interval limits. And I'm going to limit it to these two parameters to make it simple and visual for you. Let's first develop the driving lanes for these two parameters. Clearly, you need several points to develop these arbitrary driving lanes. However, based on the first 3 years worth of data, I feel pretty good about the lanes that I've drawn. After filling in the rest of the graph, we make several observations. Clearly, there's a decreasing trend for both hematocrit and MCV over the last 3 years, and both have deviated out of their respective driving lanes, even though they stay well within the reference interval limits themselves. The sad part with Tina is nobody looked at the previous data to recognize this trend. Deviation out of their driving lanes indicates a significant change and should have prompted somebody to do a further investigation in Tina. Parameters that have a high index of individuality are very powerful to you. They improve your sensitivity if you have serial data in detecting disease way before they go outside of the reference interval limits. Okay, let's go back to the erythrogram and talk about red cell distribution width. This is a parameter that I think many people ignore completely. So let's discuss it a little further and tell you how to interpret it. What is red cell distribution width? The RDW is an objective measure of the degree of variation of red cell sizes, anisocytosis. In most of our species, the red cell sizes are really quite uniform in periods of health. And that distribution curve demonstrates that feature. Most of the cells are going to be in the center. If we see a more variety of sizes in the blood film, you're going to get a wider distribution width and an increased RDW. The RDW only tells me there's variation in size of the cells, and we can get there several different ways. If there's a mixture of normal and large red blood cells, the curve is shifted to the right. If there's a mixture of normal and small red blood cells, the curve is shifted to the left. Regardless of the types of changes in sizes we have in a sample, that distribution width will be greater than normal, and that's what may be presented to you as an increased RDW. When you see an increased RDW, I can almost guarantee you that there will be morphologic abnormalities in the blood film, and it tells you you must look at a blood film. The RDW completes our discussion about the red cell indices. That RDW, remember, is a really reliable test on most of our analyzers. And when we see an increase, we can almost guarantee there are going to be red cell morphologic abnormalities. Now let's turn to the reticulocyte panel. The absolute reticulocyte count is the most valuable here. It is an objective measure of bone marrow production of red blood cells. When we see an increase, that means that the bone marrow is responding to a peripheral demand for erythrocytes. An important point to make here is that the absolute reticulocyte count is not only important for the anemic patient, but also the non-anemic patient. And we'll discuss that in a case a little later. I think we all recognize that if we're presented with an anemic patient, the first question we want to answer is the anemia regenerative or non-regenerative? And the reason for that is because the diagnostic approach for those two different processes is dramatically different from one another. And I want to make sure that I go down the right path. Therefore, I want the most objective measure of that bone marrow responsiveness, and the reticulocyte count provides me with that. What is actually happening when we see anemia with reticulocytosis, a regenerative anemia? Well, we see that when the rate of blood loss or hemolytic disease overwhelms the bone marrow's capacity to respond. Things get out of balance and we end up with anemia. And when I see that picture, I'm going to go through a long laundry list of blood loss and hemolytic disease conditions to find out what's wrong with my patient. To define the value of the reticulocyte count, you need to look at the prevalence of anemia in your practice. These data were generated from a large data set of 1 million CBCs pulled randomly from our global fleet of ProCyte DX analyzers from cats. And you can see very quickly that 25.5% of these animals are anemic. Now, we know that most of these are non-regenerative, but you can't tell that just by looking at the numbers. We need that objective measure of regeneration to classify them properly. The reticulocyte count provides me with that information. To fill in one more piece of the pie, I want to add in that reticulocytosis without anemia. Almost 4% of the cats that you see day in, day out will have this condition. And we're going to discuss this a little later with one of the cases, so I'll reserve that discussion for then. Let's look at a little more detail of that large data set we just discussed. Remember, 25% of those cats have anemia. Only 12% of them actually have a regenerative anemia. But it's important for us to be able to identify them because the diagnostic approach in those are very different than the diagnostic approach in non-regenerative anemia. There are other ways than determining the reticulocyte count to predict the bone marrow responsiveness. You could look at a blood film, but we know already that that doesn't happen in most clinics, so that's a problem. Also, in the cat specifically, it's a little more difficult to recognize those immature cells from the mature ones, in contrast to, say, the dog. So there's a couple of problems with that blood film. We could also use the indices. Remember, the classic description of a regenerative anemia based on the morphology of those immature cells is that you may see a macrocytosis, increased MCV, you may see a decreased MCHC, hypochromasia, and you may see an increased RDW because there's variability in sizes of the cells. But when we look at those 12% of regenerative anemias based on a reticulocyte count, remember the most objective measure of bone marrow responsiveness, only 19.7% of those cases have an increased MCV. 13.5% have decreased MCHC and 45% have increased RDW. But that RDW, remember, is the least specific for us identifying that immature population. Remember that when we combine different tests, we typically improve our specificity for that particular process we are trying to identify. And in the case of the regenerative anemia, if we use the MCV and MCHC changes together that fit a regenerative anemia, now only 8.4% of those regenerative anemias actually show those changes we want to see. That means that over 90% of the time, we're going to misclassify our regenerative anemias. That's huge. It gets even worse if we add the RDW into it. It goes down now to about 5% of those regenerative anemias have all three abnormalities. The reticulocyte response in the cat is different than other species, and I'll use the dog for comparative purposes. On that picture on the right, that's a new methylene blue stain preparation, and with new methylene blue, it precipitates the RNA in those immature red blood cells. The aggregates are the ones with a lot of RNA precipitated. The punctates are the ones that have a few specks of material. In the dog, the maturation of the reticulocyte goes from aggregate to punctate to mature red blood cell, and that all happens within 2 to 3 days typically. However, in the cat, the transition from the aggregate to the punctate is relatively short, within a couple of days, but the punctates stay in circulation for a pretty long time, at least 10 to 14 days, and some people even say up to 21 days. Most people ignore the punctate response, thinking that the aggregate is actually the best measure of a recent bone marrow response in sending those immature cells into circulation. That's wrong, and we'll try to explain why in just a few slides. This graphic shows information from 3 different studies. It's a composite of 3 studies done in the early 1970s, where these investigators took normal cats with packed cell volumes around 35%, bled them to 15%, and then followed them over time without any therapy. That line down at the very bottom is the aggregate retics. You'll see there's a lag period. That happens in all species, and they start coming up and they go up very modestly, and then right about 20% packed cell volume, you see they start decreasing and go back to baseline way before the packed cell volume goes back to its normal set point. However, the punctate retics, the red line, do continue to go up, and not until the packed cell volume gets up into that set point do they start decreasing in numbers. So what does this mean? Well, for some reason, we've got that magical number of 20%. And if you have a mild anemia above 20% PCV in a cat, and you do not see an aggregate reticulocyte response, don't condemn that cat to a non-regenerative anemia category. First, do a new methylene blue prep and screen quickly to see if you see a lot of punctate reticulocytes. I wouldn't recommend counting them, but you can screen the slide and recognize there are a lot of them there. That's all we need to know to say regenerative anemia. To demonstrate what we just discussed, I'm going to use a case from Purdue. It's a case of mycoplasma haemophilus anemia. On day 2 of hospitalization, the packed cell volume was 8%. The image on the left is the diff-quick stain prep, which shows all the features of a strong regenerative anemia: anisocytosis, polychromasia, and those big pale blue cells. Those are going to be the aggregate reticulocytes. The image on the right is the new methylene blue prep from that sample, and notice that the aggregate reticulocytes strongly predominate. This is a strong regenerative anemia. Now look at this cat at day 10 of hospitalization. On the left, the diff-quick stain prep, I don't see polychromasia anymore. On the right, all I see are punctate retics. I don't see any aggregate retics. And remember that magical number of 20% packed cell volume, the aggregates have gone back into the marrow and they're not being released anymore. However, this is still a regenerative anemia. So, lesson learned: if you see a very mild anemia in a cat with a packed cell volume greater than 20%, do a quick new methylene blue prep and scan to see if there are a lot of punctate retics. They should be many in numbers for it to be classified as a regenerative anemia. Don't condemn these animals to non-regenerative anemia because of the lack of the aggregate retics. I need to complete the discussion about the reticulocyte panel, and that's talked about the reticulocyte hemoglobin, but I'm not going to spend any time here because we're still learning a lot about the reticulocyte hemoglobin in the cat specifically. I'd refer you back to the resource tab you see on your screen to see what might be available for us from the IDEX website. What you do need to know about retic hemoglobin is that it is the most sensitive indicator of availability of iron. The most common situations where we see that are either during true iron deficiency, where there isn't any iron present, or actually more commonly in a situation where we have iron limited red cell production, where there's plenty of iron, but it's not getting to the red cells, and that's during active inflammation. The percentage of cases that have that low reticulocyte hemoglobin represent about 3.3% of the CAP population. That's pretty significant. More importantly, if you look at all the pieces of the pie that are associated with that reticulocyte panel, you see that about a third of all CAT CBCs need that reticulocyte panel to recognize and accurately characterize disease. This is a really important finding for us in feline medicine. We'll learn more and more over the next few years, but right now, reticulocytes are important in the cat, and we must recognize that. Now let's put our attention to the thrombogram. I think most people only think of platelet numbers as part of that thrombogram, but there's much more there. And let's discuss those individually. As within the erythrogram, where we started with the red cell mass, we're going to start the thrombogram talking about the platelet mass. We only have two parameters here as part of the mass: the platelet count itself, which is what we've depended upon for years in veterinary medicine, and then there's the platelet crit, or the PCT. And in many situations, that platelet crit is actually a better measure of the platelet mass than the platelet count itself. We're interested in talking about, well, how much phospholipid content in the membrane and cellular components are available for the coagulation process. And the mass of platelets is, in many, many cases, more important than the platelet count. The point we want to make is that the presence of many small platelets may be functionally similar to that of a sample that has fewer large platelets. And in both of those cases, even though the numbers are different, the platelet crits may be quite similar. Once more, that total mass with the platelet crit is more critical than the platelet numbers themselves. And as a poster child, not speaking about a cat here, is the Cavalier King Charles. These dogs, at least the families with the macrothrombocytosis, have fewer numbers of platelets, but they're larger than normal compared to other breeds of dogs. Yet their platelet crit is similar to those of other breeds of dogs. And if I go to a species that you probably are not working with, the mouse, mice have very small platelets. We count them in the millions per microliter rather than hundreds of thousands per microliter. Yet again, they have platelet crits similar to those of normal dogs and cats. Many small platelets equals fewer large platelets when it comes to functionality. Unlike in the erythrogram, there's only one reliable index for the platelets, and that's mean platelet volume. This is a population description, meaning that it's a mean value, and therefore we have to have really significant numbers of abnormal morphology present before we see deviation outside of the reference interval. So it's a pretty unsensitive indicator of abnormalities. There's a little more of a problem in the cat. In the cat, even in the normal cat, we may see a lot of variation in platelet sizes, and we may see some pretty large platelets as well, again, in the clinically normal cat. There are some principles we can apply, like we do in other species, and let's talk about those. Because of the variability in platelet sizes and the possibility of large platelets in a normal cat, we have to interpret the MPV very cautiously. In most species, when we see larger than normal platelets in circulation, that's an indication to us that the bone marrow has increased the rate of production of those platelets because of a peripheral demand for platelets. Now, we can use this in the cat in some situations. And if I can document that there's a true thrombocytopenia and I see large platelets, increased MPV, one thing I can consider is that that's much more likely to be a process where there's peripheral consumption or destruction of platelets rather than a central bone marrow failure of decreased production. By far the most common time we see a low platelet count in a cat, it's associated with pseudothrombocytopenia due to platelet clumping. So it's important for us to be able to distinguish between these two. So let's discuss that now. Why is it important for us to have this discussion? Well, platelets are important. The most common bleeding disorder we see in veterinary medicine is associated with thrombocytopenia or decreased platelet mass. Remember, platelets are critical for both primary and secondary hemostasis. Therefore, it is essential for us to have a good handle on the platelet mass in all of the patients we see, from preventive care to sick patients. Platelets are a big deal. In vitro platelet clumping is pretty common in veterinary medicine, especially in the cat. Anything that can delay collecting the blood rapidly and getting it into the EDTA sample to properly mix to prevent platelet clumping will give you platelet clumping. So if you have a hard time collecting a sample in a small vein, if the animal's fractious and it's difficult to get a good stick, or maybe the animal is very sick and has low blood pressure delaying the collection process itself, all of these conditions that delay getting it to the EDTA have the propensity of seeing platelet clumping. Platelets do what they're supposed to do if they're given time, that's clump. Now, how do we determine if there's presence? Well, in some analyzers, you may actually get a message that says platelet aggregates detected or something like that. But that doesn't fit most of our analyzers. Even if your analyzer does give you a message about possibility of platelet aggregates, it will likely tell you to look at a blood film or look at the cytograms to confirm that process. Even if you don't get that message, I would strongly recommend that you look at a blood film to confirm the presence of platelet aggregates. The process of confirmation of platelet clumping is relatively simple and rapid. You merely have to screen the blood film at low magnification. In this particular case, here's an image from the feathered edge where there are large clumps of platelets. But don't restrict your evaluation only to the feathered edge because we can see platelet clumping in the monolayer and the body of the smear as well. No flagging system is 100% sensitive. However, you may get clues to the presence of platelet aggregates by looking at the cytograms from your analyzer. These are images from the ProCyte DX analyzer from IDEXX, and you can see the differences on the normal on the right and the abnormal on the left, where you have this curvilinear array of orange dots. Those are the platelet aggregates. And for further information, I'd recommend you back to going to that resource tab on your screen to get more information specifically about the IDEXX hematology solutions. Let me restate that point. No hematology analyzer is 100% sensitive in either giving you a message or showing you evidence of platelet aggregates just on the cytograms. And what I strongly recommend you do is never accept a low platelet count from any hematology analyzer without confirming with either the cytogram or blood film review. Do this before you start investigating the cause of a thrombocytopenia. Before we look at a few cases, I want to list very briefly some of the common red cell and platelet abnormalities we see, and we can use all that information we just talked about, the CBC, to differentiate the different causes. By far, the most common red cell abnormality we see in the cat is anemia, and generally it's secondary to some other process. The non-regenerative anemia is by far the most common, and we can see this frequently with inflammatory disease, but we can also see with other conditions like chronic renal failure or endocrinopathies or chronic blood loss, especially in the cat with inflammatory bowel disease, where we have this smoldering loss of blood throughout the process. Regenerative anemia clearly does exist, and remember, when we have a regenerative anemia, we have to go down a long laundry list of both blood loss and hemolytic conditions. Infectious disease in the cat with mycoplasmosis is clearly near the top of our list of differentials. Immune-mediated disease is possible, acute blood loss, and remember that oxygen injury, Heinz body hemolytic disease, is more common in the cat than we see in other species because the hemoglobin itself of a cat is more sensitive to oxygen injury than other species. Then don't rule out things like mechanical injury, cardiac disease, vascular neoplasms. They're much less common, but all of that laundry list has to be considered. Thrombocytopenia is clearly the most common platelet abnormality we see in the cat. And typically this is pseudothrombocytopenia associated with in vitro platelet clumping. Splenic sequestration, when the spleen is enlarged, congested, or even neoplastic in nature, is possible, but those animals still have adequate platelets for the normal coagulation process. True thrombocytopenia, this becomes a little bit of a diagnostic challenge for us. We need to differentiate between peripheral consumption, like inflammatory disease and DIC, as from peripheral destruction, infectious causes like feline leukemia virus infection or FIP. Immune-mediated thrombocytopenia does exist in the cat. However, it's pretty uncommon and it's a little bit of a challenge to get to that diagnosis. Typically, we come in through the back door making that diagnosis based on our management of the patient. Decreased bone marrow production is possible, but remember, this is less likely. And when we do see it, it's most commonly associated with infiltrative bone marrow disease like leukemia and lymphoma. Now let's try to apply some of what we just spoke about in some real case scenarios. We're clearly not going to cover everything, but it will show you how to approach the CBC in these case examples. Our first case is Mickey, a 12-year-old male neutered domestic short-haired cat that presented with labored breathing, acute lethargy, and significant weight loss over the last several months. On physical examination, the primary abnormalities that were seen was decreased body condition score and depression. The diagnostic workup in Mickey included both laboratory work and some diagnostic imaging. And as a spoiler alert, the diagnosis and management of Mickey turned out to be a diagnosis of cardiomyopathy, and after fluid therapy was sent home for the proper medications. In the laboratory evaluation, we're going to focus on the hematology, but need to note that the chemistry panel was completely normal. There's no significant abnormalities. Similarly, urinalysis had no significant abnormalities. But let's now talk about the hematology. In Mickey's CBC, there were only two abnormalities and they were both in the erythrogram. So here's the data, and notice I've also shown you the cytogram. Specifically, this is from the ProCyte DX, and we'll see how to use that when we do the interpretation of the data. But I think right away, you can see that Mickey's dot plot for the red cells and platelets is different than that of a normal cat. That's the starting point. The RDW, the red cell distribution width, remember that's a measure of the variation in red cell size, is slightly increased in Mickey. And by itself, we probably would question the significance of that. However, when we look at the dot plot for the ProCyte DX, we see support for that variation in size. The red dots on the plot represent the mature red blood cells. And look at the span of the red cell population on that y-axis, which is a representative size of the cells, compared to the normal one below. Clearly in Mickey, that spread is wider, suggesting that there really is variation in size. The next abnormality is the reticulocytosis, and this clearly is significant. It's over 3 times the high end of the reference interval for the cat. So that we need to investigate this. Also, remember, we have to confirm the results that we get on the report, and the dot plots help us again. Those purple or pink dots represent the reticulocytes, the immature red blood cells. The fluorescent dye that's used on the ProCyte DX is a measure of the amount of RNA or DNA. And in this case, there are increased numbers of cells, young cells with RNA in the cytoplasm in Mickey compared to that of the normal pattern down below. We start the blood film evaluation at a low magnification, and we immediately recognize several abnormalities. First, let's see, the density of the red blood cells is pretty normal, but remember the hematocrit in the CBC was normal as well. There's clearly increased central pallor compared to a normal cat blood cell, and there's also a lot of variation in size. Remember, that goes back to the RDW. At a higher magnification, we can now see other abnormalities a little more clearly. You'll note that many of the larger cells in the film actually have a pale blue staining appearance. These are the polychromatophils, which represent the immature red blood cells, the reticulocytes. So we already confirmed the reticulocytosis with the dot plot, but this adds additional support that yes, there truly is an increased number of immature cells in circulation, suggesting a bone marrow response to a peripheral need. As we scan the blood film, we find some very small red blood cells, as well as maybe some fragments of red blood cells. These are significant abnormalities, and we'll kind of summarize how we interpret these in light of Mickey's underlying disease process. Mickey is one of those cases of reticulocytosis without anemia. And if we didn't have the reticulocyte count, we might not have even led our investigation down this path. We see increased rate of production because there's a peripheral demand in these situations, and it's either a compensated hemolytic or blood loss disease. The pathology we see on the blood film says there are smaller fragmented red cells. This is likely associated in Mickey with the cardiomyopathy and mechanical injury. There's also increased central pallor, hypochromasia, and this is most commonly associated with chronic blood loss. Now, we didn't see that with the indices, but we see it on the blood film for sure. And after reevaluating Mickey, they found some flea dirt. And then they get back information from the owner that, oh yes, there are other cats in the household that have had problems with fleas. So there's your chronic blood loss situation that we need to stop right away. Remember, we saw a similar diagram when we were talking about regenerative anemia. In that case, we see anemia because the bone marrow can't keep up with the rate of blood loss or hemolytic disease. However, if the processes are mild or early enough, the bone marrow can compensate, and what we end up seeing is a retaining of the red cell mass numbers, but a reticulocytosis showing the bone marrow response. When you see that, you need to look at the same list of differentials for blood loss and hemolytic disease as you do when you have a regenerative anemia. Our next case is Nova, an 11-year-old female spayed domestic short-haired cat. And the presentation was really kind of weird. It was walking funny, it was lying near the water fountain, and periodically the cat seemed to improve on its own. So this has been going on for a few weeks. The physical examination, they recognized some weight loss over the last couple of years. They also recognized some muscle wasting along the spine and moderate dehydration. The obvious diagnostic workup in Nova would be to do a complete minimum database evaluation. However, the owner was concerned about cost, and the veterinarian was only allowed to convince the owner to do a CBC to start. The only significant abnormality in the entire CBC was a very mild increase in RDW, red cell distribution width. You'll notice I've given you the dot plots, or the cytograms. These again from a ProCyte DX. We need to start looking at those more and more. As with Mickey, when we look at the dot plot and look at the red dots, the mature red blood cells, and look at the span of those red dots, going from top to bottom, you see that it's much wider than that of the normal cat below. That supports the anisocytosis. But even more importantly, look at how many dots there are down in the low size range for the red cells. We must look at a blood film, not only because of the RDW increase, but also the dot plot changes. When we look at the blood film on Nova, we recognize quickly that the density of the red cells is pretty normal, and that's supported in the CBC with the normal hematocrit. However, there is marked shape changes in the red cells, primarily poikilocytosis. There are some acanthocytes in there, and there's mechanical injury evidence by the fragmentation going on. When we see these types of changes, this doesn't provide us with a very specific diagnosis, but it gives me a direction to go diagnostically. And I'm going to be looking for things like liver disease, splenic disease, kidney disease, cardiac disease, and other conditions. Again, it doesn't have specificity, but it's clearly abnormal. Because of the hematology abnormalities, the owner allowed the veterinarian to do further diagnostics. The veterinarian eliminated splenic disease based on their diagnostic imaging evaluation of the abdomen. In the chemistry profile, the only significant abnormality was a very mild increase in sodium and chloride, likely due to the dehydration. There was no evidence of significant liver disease or kidney disease. However, because of the morphologic changes in the red cells, they pursued evaluating the kidney, and they eventually did get a urinalysis, and they identified a lack of concentrating ability and a significant proteinuria. So Nova had chronic kidney disease, and that easily could explain the morphologic changes we saw. The prognosis, I'm afraid, for Nova was very guarded, and the owner allowed euthanasia to take place. The last case that I'd like to discuss very rapidly is that of Emmett. Emmett was an 11-year-old male-neutered domestic long-haired cat that had presented with very gradual decreased activity and appetite for weeks duration. It had not been seen by the veterinarian since a very young cat at the time of neutering. On physical examination, Emmett was found to be thin with muscle wasting. There was mild fever, and they also identified a subcutaneous mass that they felt was an abscess in the ventral neck region. When evaluating the erythrogram for Emmett, we look at the dot plots first, the cytograms, and we don't recognize any abnormalities really in shape or density of any of the different populations of mature and immature red cells compared to the normal pattern below. Looking at the numbers, everything's within reference interval limits, so there are no significant abnormalities identified in the erythrogram. In the thrombogram, the only numeric abnormality is that of a significant decrease in platelet numbers, not enough to allow spontaneous bleeding to take place, but still a very significant decrease. And if we look where the platelets lie on the dot plot, and you compare the area where normal platelets should be located for the cat, you see a very slight decrease in density of those digitized events, and that correlates to that low platelet count. However, you also see a disconnect between the platelet number and the platelet crit. The platelet crit is suggesting that there is a low normal platelet mass. The platelet count is suggesting a decreased platelet mass. Remember our discussion earlier about the platelet crit might being the better measure of the total platelet mass? Well, even in the dot plot here, we get a clue as to why we see the disconnect here. That red circle is surrounding digitized events that represent larger than normal platelets for a cat. And remember, platelet mass doesn't necessarily mean the platelet numbers have to be the same. If I have larger numbers of large platelets, I don't need as many of them to satisfy the clotting process. Looking at Emmett's blood film, we rapidly confirm there's no evidence of platelet clumping. We also support the thrombocytopenia reported in the CBC. We only see 2 to 4 platelets on average per 100x oil objective field of view. Normally at that magnification, we should see at least 8 to 15 platelets. Additionally, we see some large and giant platelets, and there's a good example of one of those giant platelets in the upper left quadrant of this photomicrograph. So how do I interpret the thrombocytopenia in this particular case? Well, it goes back to identifying what that mass was in the neck. That truly was an abscess. And remember, platelets can be consumed in an inflammatory process. I'm also going to interpret the presence of those giant platelets as evidence of bone marrow response for the peripheral demand. And as they resolved the inflammatory process, Emmett's platelets came back into the normal numbers very rapidly. So I think that explains what's going on within Emmett. Well, we reached the end of our erythrogram and thrombogram tour. I know there was a lot of information in there. I hope some of it becomes practical for you in your day-to-day operation. I want to thank you very much for joining. And also, I want to bring back to your attention that resource tab. If you want more information about the IDEX hematology solutions, or if you want to fill out a contact form for somebody to contact you, you can do that with that resource tab. I think we're going to try to answer some questions now. But if I don't hear from you, have a great rest of the meeting.
Wow, thank you so much, Dr. Di Nicola, for a fantastic presentation. It was really good to have a reminder of red cell morphology, but then also how we can use that information and interpreting what we're seeing on our results in practice, and really useful, I think, for our listeners for kind of day-to-day use, really. So thank you ever so much for going through that. We do have some questions, so would you be okay for me to pick a few for you and go through some?
Absolutely. Go get them.
Brilliant. Okay. So first one that we had is from Shao, and he's asking about cases where we have the erythrogram suggestive of anemia, either non-regenerative or regenerative. Can't say it. But the reticulocyte count doesn't really confirm it. And actually vice versa as well. So maybe our actual counts are okay, but our erythrogram doesn't look right. What would you suggest we do when the two don't match really?
Well, I mean, that actually happens more often than we would like, and it's even more problematic in the cat. I think first we as veterinarians need to really grab the power of what that reticulocyte count is telling us, and the analyzers have really progressed quite nicely in their ability to identify at least those aggregate reticulocytes. So if you do have a reticulocytosis with or without the anemia, that warrants further evaluation, because if there is an anemia, it puts it into that proper category of regenerative anemia, which now gives further diagnostic direction to find the cause. If you get the reticulocytosis without anemia, at that point, now you have to start digging for underlying disease that might be quite occult in nature. The animal's hiding the disease itself, because that's a signal to you that there is something wrong with the patient. And I've seen so many cases now of Heinz body hemolytic anemia, immune-mediated hemolytic anemia, even mycoplasma infections, but a variety of those conditions where we find that. And that was the only clue. And by identifying that early, you need to go to the next step. And this first step is looking at the blood film. Now, remember the situation in the cat, that if you have a mild anemia, with a manual pack cell volume, or your hematocrit is a little above 20%, but below the low end of the reference interval, that's the problem area we have in the cats, because none of our analyzers can count those punctate reticulocytes correctly. And this is where, you really need to put it into those one of two buckets, non-regenerative or regenerative. And to get there, you absolutely do need to do that new methylene blue preparation and not count them, but just scan the site. If you easily find many punctate reticulocytes, you can put it into the regenerative bucket. If you don't find them, it's in the non-regenerative bucket. And just like we started with, you go into completely different directions for diagnostically. So it's not an uncommon question. It's not uncommon of a presentation either. So it's a great question. I don't know how many times I've answered it. I wish I could come up with the best answer so I can solve problems easier.
Yeah, of course, that would be the magic pill, wouldn't it? As such, if we could answer that so easily for everyone. Brilliant. I think that also answers. Lionel had a question about sizes of punctate reticulocytes and identifying regenerations. I think that also answers his question. So we shall move on. So Alexander's asking about cats on methimazole and whether they develop anemia, but I think probably more important from your point of view is how do we differentiate whether a cat with anemia, is it due to a drug that they're having or something else? How can that help?
I'd like to have a pill for that as well, if we could. That's a challenge. You have to understand that. Well, first off, if we put it into the regenerative anemia categories, with or without medications, the blood film is essential. And in most of the cases where we see regenerative anemia, we also see morphologic changes that can give us a clue as to what the cause is. So many of the drug-related, both non-regenerative and regenerative situations, really don't have a good red cell morphology abnormality. But if I see acanthocytes or poikilocytes, if I see mycoplasma organisms, if I suggest there might be spherocytes, and this is very hard to do in the cat because we don't have that central parallel of the palate to begin with, but that'll lead you down thinking about an immune-mediated type process. If I see schistocytosis, fragmentation, I'm going to be looking for mechanical type changes. Like in the cat with the cardiomyopathy, just turbulent flow of blood through the heart can cause fragmentation, and it gives you direction to do your further diagnostics, investigate those causes. Oxygen injury is really a big one in cats that, I don't think we appreciate well enough. We see it pretty commonly, not just with the acetaminophen toxicities, but when you start looking at some of the other underlying conditions like diabetes and just systemic lymphoma and hyperthyroidism, that those are the conditions I start looking for if I can find those Heinz bodies. In many cases in the cat, they're much smaller than the dog. So once again, that new methylene blue stain really comes to your rescue because it'll help enhance the identification of those Heinz bodies. So another good question, another good pill for us to generate to answer it quicker.
Yeah, brilliant. No, it's really important to understand it, isn't it? And actually, sometimes it's nice to know that these things aren't easy. They're difficult, but it's not because as individuals we don't know or understand. It's because there are complicated situations, and we have
absolutely. And hematology is not easy itself. I mean, there are way too many branches and directions to go to. And I remember what I said earlier in the presentation that even if we're presenting the analyzers, and I'm talking about even the analyzers at the reference labs, if you present these analyzers with a really abnormal sample, maybe it's an FELV myeloproliferative type disease, or it does have a severe inflammatory process with a prominent left shift, those are even challenging for the analyzers. And that's why we use things like the cytograms to make sure that we're getting results. Now, I'm afraid hematology is not easy. That's good for me, though. That's good job security for me.
Well, that's true. That's true. And you've done a great job explaining it today in this presentation as well. So you get there's loads of, we've got lots of comments coming through and lots of thank yous, great presentation. So some really, really nice feedback as
good
well.
To hear.
So that's good. We'll just pick one last question. This is quite a nice one because it's actually about the devices. So the question from Therese is, would you recommend to always do hematology on the same device? Now, she's saying obviously if you're doing it in-house, then you probably will, because you probably only have one machine. But if you're sending it external, for example, would you recommend that you are repeatedly always sending it to the same external laboratory so that you're using the same equipment and machinery to get your results?
Yeah, that is a great question, because I see a lot of practices that do most of their in-clinic hematology on their sick patients where they want the results right now, but they take advantage of the money savings for the customer by sending it to the reference lab and, say, a wellness patient. So they use both in-clinic and reference lab. I think both are obviously valid ways to look at it. But from my perspective, I strongly recommend using the same analyzer as much as I possibly can. If I get a sick patient, it probably doesn't matter. But if I want to take the power of, remember that index of individuality, and this is where the erythrogram really shines brightly, because that'll help us pick up a disease a lot earlier than if we just rely on the clinical signs. And I'll give you a quick example. We bring our cat, Willow. I introduced Willow to you in the practice. Mm-hmm. In fact, we just got a notice today. They want her to come back because we're at a 6-month time period. And so we religiously set the appointment. And when IDEXX in North America established a really nice package for the wellness testing, preventive care testing, the veterinarian, well, about a year ago now, called me at work and said, hey, your wife said to do this, this, and this, because I give them a long laundry list if I want them to test. And he said, I can save you $150 if I send it to the reference lab. And I said, no, I want it done there. And I didn't go into the details of why. And he tried to get me to push it a couple of times. And I said, no, I'd like you to do it there. Well, during the evening, you can imagine there was a long conversation between my wife and I. Why didn't you want to save $150? And I had to pull up in VetConnect Plus and show her those graphs and say, this is why. I know even our technology in our reference labs is very similar to that of the ProCyte DX that this veterinarian uses. But there are slight differences. And I want to keep the consistency there, if at all possible, because I want to be able to pick up developing renal disease way before I have any problems so that I can start intervening and supporting that animal. That's a great question. Remember, whether you use a reference lab or you use your in-clinic system, you're going to get good results. But there are going to be some slight differences because of the methodologies being very, very slightly different, at least within the IDEXX system. If you use a different lab that uses a different technology than what your in-clinic system is, then you're going to see even greater differences. And then I didn't even speak about the possibility that, things change with time. So if the blood sample doesn't get to the reference laboratory for 12 to 24 hours, there are going to be some changes. There's some changes in morphology. We'll talk a little bit about that with the white cell webinar we're going to do. But even red cells, the MCV, those cells sitting in the DTA swell, and the analyzer detects them as being larger at the reference lab than it will be in the in-clinic system. And it could be as many as, 3, 4, 6 femtoliter increase in size. And that now messes up my whole driving lanes for following MCVs. So, great question. I think you said that was the last one. So I want to thank everybody for participating and listening in. And I hope some of the material was of value to you. Again, thank you very, very much for giving me this opportunity at ICC as well.
No, we're absolutely delighted to have you. It's been brilliant. And again, we're still getting lots of feedback. Thank you. So I just want to everyone to say, don't forget that there is a little webinar feedback form as well. So if we can capture that would be fantastic, because it's really good to get your feedback as well. So thank you everyone for that.
And don't forget them to use that resource button as well. There's absolutely a huge amount of resources that we have available for you. We want you to know how to use your analyzers and get the maximum out of them. So, let's work together.
Yeah, absolutely. Like you say, the resources are there, it's a big investment, isn't it? So why not get the best that you can out of it? You spend a lot of money buying these things, so make the most of them. Absolutely. Well, I just want to say, Dr. DiNicola, thank you once again for an absolutely great presentation, and of course for your additional time to go through some questions and this little discussion at the end as well. So really appreciate it.
Totally my pleasure.
Thank you very much.
Totally my pleasure.
Of course, we do have Dr. DiNicola back with us, and that's on the 17th of November. Be looking at the 5-part differential, so the white blood cells next time. So if it's anything like tonight, obviously it's going to be another fantastic presentation with lots of information for you to kind of take back and apply just in the day-to-day practice as well. So it is open for registration. If you pop over to our website, then you can sign up now and you'll get the reminder. We have recorded this session, which means that you can watch again. So you'll get an email through give me about half an hour or so after this, and it will be up on the same link as you're on now. And you'll be able to watch again, and you can always go back. Those resources will remain there. So all the lovely resources from IDEX and also the certificates of attendance, etc., that will all stay there. So there is the opportunity to come back and revisit those as well. And
if you do go back and if you're going to come back and listen to it again, make sure you have a big bowl of chips and a big pint of beer, so it makes more sense to you.
Brilliant. Good advice. Fantastic. And the same will happen with the next, all our webinars have the same format, so we always record them. So even if you think, 17th of November, I'm going to be busy, working, whatever, then do register anyway, because that way you will get the link to the recording. So even if you can't attend on the night, you will always be able to access the recording as long as you register. So it's really important to register for that. So please do that. You can do that now. You can pop over to our website. Like I say, just check out the resources, and if you could kindly fill in the feedback survey as well, that would be fantastic. But I think for now, I appreciate we have a lot of people from around the world, and it's 9:15 here in the evening in the UK. So in a lot of other countries, it's even later. So I appreciate the time of day for most of you, and the fact that you've stayed up to listen to this session. So thank you to everyone. We've had a huge number of people log in tonight. So thank you to each and every one of you. And of course, again, Dr. Di Nicola, for your time. So until the 17th of November, which is our next session together, we'll see you then. Until then, goodbye.
Bye now.
Bye-bye.
Have a great day or night.